Next, we'll hear from Rohit Khanna.
Afternoon, everyone. I think hope everyone is awake after lunch. So, when I was told by Suzanne that you have to put in 5 slides, 20 years journey over the 20 years. So, not more than 5 slides. That was the mail which said. So, it was thinking, how do we put all the things in 5 slides? And I thought, let me try and see. So, this is about research used to be a dream in the past. And I think anywhere in medical college, nobody used to take research very serious. And I never thought I will become a researcher also, and I will go into do research. My only job was to uh, see patients do surgeries, and everybody said my serious. Everybody in India says what you will do with research, go out and start practice and get money, and that. So that was the whole story, and I was not very convinced, and I landed in 1996 in Prasad, and I was interviewed for a fellowship. Fortunately, I was got selected for the fellowship. And one thing Dr. G. N. Rao told me was, when you are coming for a fellowship, you also would like, we would also like you to be part of one of the study which you are doing is population based. The Andhra Pradesh ITC study. It just you will be the examining ophthalmologist and you will be also you part of authorship of many papers and all. I had no idea what was that. Okay. The part of fellowship will do it. We went to the rural areas, we examined, it was a very, very detailed comprehensive. It's just like you examine a patient in the clinic, it was every participant was doing a complete examination and it took almost 4 years to finish that study. We finished it from started in 96 and 2000 we finished it. I was just that was my first exposure to research. And the lead analyst was a principal investigator, but I had no idea how to write it, how to do analyze it. It just was, I was examining ophthalmology. And then came, I joined back in 2003 and I was asked to go to London to do a master's in community eye health. I had still no idea what it's all about. I just went there. I thought we go around London and have a nice fun time. That's what most of people think. And when I landed there, I started understanding this is what research is all about. I first term was basically looking at epi biostacks, and I started getting interest because the way the teaching was happening, we never nobody taught us in that way. So that grew my interest in research in public health and mental slide clear. Alan was one of the best mentor I can ever say. Was the way he used to make complex things simple. I think nobody in this world can do it. So he used to make things so simple. And fortunately, I was fortunate enough to Alan being my mentor for my thesis, and I got a thesis which is about. I will didn't even know how to select a topic. I went with 200 topics to insert, list on all the topics, prioritize them, and come back to me. And it was like a big exercise with Alan, which I almost took almost 6 months to finalize the topic. So he had a very nice system of how you finalize students finalize the topic. And I did the first study, which was an ICH is unlike other masters where you have to just do simple data analysis. ICH fellowship involves you to go to the ground and collect data, which means you get your data, come and start analyzing the data and write up. And that's the most important part of ICH fellowship, where you learn to do how to conduct your own independent. Though it's a small research question, but you learn that process, the entire process of it. That was the first exposure to my own data collection and on writing the papers and all that. And after the uh, after the masters was over, I was asked to write the paper, and I don't know which journal. So we started from topmost ophthalmology, and Alan said, "Okay, you try ophthalmology. Let's see how it goes." So it took almost like 8 years for me to get the paper published, my first paper, and it went to almost 7, 8 journals, but I didn't give up. The issue was like I continued pursuing it. Perseverance was the key actually, and before that I published other papers actually. So, but I continued with this paper because I put so much of effort. See, 90% there. So why should we leave it? Every time we get reviewer comments, I think we improved on the paper, and finally it got published. And it was 2012 when I got this paper published. So it almost took a nearly a decade to get the paper out. But it was still out, which was good thing. And we were thinking of some big questions, what should we do and all. And that time we had a BC meeting with again ICH. Player and Dr. Murthy came, and then we thought we'll replicate the Andhra Pradesh IDC study, which we had done almost a decade back. Can we go and look at it? There is no good data on incidence from India. There are data on incidence from other parts of the world, but mainly in Caucasian population and one from Barbados, but not much from Southeast Asia and all. So I thought it's a good opportunity, and then we had a very long follow. So it was clear, and automotive suggested that let us do a feasibility exercise and see whether how many people are there. We examine 10,000 people, how many are available after 50 years? And that's a great question. Because if nobody is there and people are gone, what you will do is investing so much of resources in that. We did a tracing exercise. It was almost like 6 months we found. What we found was we had one urban and three rural areas. All the people in the urban areas had disappeared. The slums, the locations have gone up. There are huge buildings in that. Lot of urbanization happening in Southeast Asia, and Hyderabad was part of that. But unfortunately, rural areas there was not much of people have lot migration. So we could trace almost 70% of the people there, and we thought this is a good opportunity. And we wrote a grant proposal, and we were fortunate enough to get the grant through, and that's how we designed the first big epidemiological study, which is a longitudinal cohort study of Andhra Pradesh IDC study, which is a 15-year follow-up of the cohort of baseline. And it was huge amount of learning. It took almost 4 years. So we could find out 5,395, which is 70% of the total population. So we could get all these people back, examine them. It took 4 years for us to get all of them back. And, we could examine, and then probably we wrote a lot of number of papers from that. Still there are going on. There are still many papers going on, and I submitted one of the paper as abstract for this meeting. And Suzanne said, "You don't know, you can't present this. You want you something else to be present here." So I told, "Okay, fine, Suzanne. What do you want me to do?" And Jackie and Suzanne wrote to me that you have to come and talk about this. Okay, fine, we talk about this. So these papers are still ongoing. There are like a couple of papers more in pipeline. So almost we finished in 2060. But still the data is so rich. It's amount of time you invested in the past 4 years. I think that will give you a rich kind of data source which you can keep, right? So investment in the beginning is a very key when you start a study. There are a lot of issues we'll talk about it, but investment in the beginning is the key. And if you do a right kind of planning, it took almost a 1 year for us to plan the study also. Like people in the institute told us, what you're doing for a year, you're not even started till now. I told it's once you start and you don't collect the right kind of data, then you are in trouble, and then you can't go back. So it's always better to plan, pilot it, and then start it. Go slow in the beginning, and then you can leapfrog. But I think the initial planning is a key for any data collection to make sure that data is collected properly. And these to every quarterly go and review the data ourselves, what data is being collected. That is how we collect it. And the second was rapid assessment studies. I think my colleague Srinivas who is here has led a lot of rapid assessment studies, and I was part of couple of them. I think we did almost 20-25 Srinivas. 27 rapid assessment studies in our 4 states, in Andhra, Telangana, mostly in Andhra and Telangana, to some extent in other parts. But in we did RAB, we did Ravi, and we did multiple versions of it have come out, and that was another. So this is a quick way of getting data like RAB. If you're doing RABs, it's good to have a RAB, but it will just give you, if you look at any RABs, it will give you what's happening over a period of time, the trends. But if you want to really have a hardcore data, then you have to go ahead, detailed epidemiological study. RAB will give you a snapshot of what's happening at a given point in time, which is important for us for planning and policy purpose. But if you want a real data of something which is novel, then probably you may have to think of some population-based data. RAP, there are a lot of innovation which happened. It started with racks actually. We did initial first racks. 2006 we did the first racks. And then came RAP, then came the Ravi, and now RAP, multiple versions are there. Now Ravi and multiple names have come now. So all of them we have tried, and it's a method of doing. But I think that also requires a lot of planning. You can't just go and tomorrow and start from any village and pick up. So there is a lot of planning in that also. So first session was taken for us by Dr. Shamana in 2010. And probably since then, I think we did look back and we continue doing that because it gave us data on what's happening in the population, in our population. And we did multiple RABs or Ravis in the same location to show the trends, what's happening over a period of time. And so the trends also was quite encouraging that when you are there, a lot of things which have changed because of your intervention rather than uh, it's a particular time frame. This was the rapid assessment. And then came another area was children eye health. And this was another big initiative which started in 2014. Again, there was no population-based data from children in prevalence of blindness. Most of the data when we looked at Spoon for the Blind or school screening and all. So there was no, we thought Why can't we? And then the question is to tell us this. It's very difficult to collect population-based data in children. Huge sample size is required. The prevalence is very low. So we thought, let's go and start it and see what happens. And the first time we did sample size calculation, it was 50,000 sample, 50 or 60,000 sample. So we had to examine 50, 60,000 children. Then you can't only go to school. You have to go to where are the children available. Children available in school, school for the blind, special school, at home, and multiple locations. You have to find all the children to make sure that all the children are represented in your data. So we went and collected data from all the children. But fortunately, what we saw was like 95% of children were enrolled in school. So which is a good thing, that at least in state of Andhra Pradesh. But this is not true in many part of the country or many part of the world where all the children are in school. So we could trace 95% of the children in school, and this is part of the ISGEO project which we. This is about, we wrote almost 10 to 15 papers from that. We did first in Krishna 50,000, and then we did 500,000. Almost now we have data of 1.5 million children, which we are still writing. There are some papers that come out still are in the pipeline. And then other thing was, the same time we started also collaborating with other organizations like Asian Epidemiology Consortium, which is basically all the studies which are done in Asia, because there used to be initially came the vision loss expert group, which is a consortium of all the researchers across the world who are involved in population-based studies, and we are fortunate to be part of that consortium. And then we had Asian Epidemiology Consortium, where all the studies done in Asia, probably one part of that consortium. So getting into consortium makes a very big difference, because consortium papers are likely to go into high impact journal. So when you go, you do your research, but at the same time try to do collaborations with others, so that collaborative research, multi-center research, I think probably a way to go forward, because single center studies are not likely to go into good impact journal, but at least you want to go to very high impact like Lancet Global Resist and all that. Either the question should be very novel, that nobody has done it, you are doing the first time in the world, or it should be a big consortium research. You want to go into this kind of journey. So we started getting into consortium research, and now we have consortium with multiple organizations across the world. And then my colleague Srinivas also started looking into elderly care. So then other area which he started venturing was elderly care, because that time the elderly population in this country was booming up, and then there were a lot of issues with the elderly. The first study he did was the home study, where we looked at the data on the elderly homes, and this was part of his Welcome Trust grant. And at the elderly home, we screened all the nearly 900 plus participants who were elderly for all the causes of visual impairment, and also went into other conditions like hearing defects, depression, health issues, quality of life, other sensory impairments, systemic comorbidities. Started venturing into other areas, which are basically intervention in this area will impact sustainable development goals. And that was something which we started getting into. And then recently, during pandemic, I think we got a mail from Nathan that he wanted to plan a series of trial which is called Engine. I think it got inspired by what was Prosper has given us, and then probably Engine was something which is what another big game changer. Every question was so novel that you cannot think, you can't even think about that this kind of question that right. It was 5 years back. I think we came with whether vision can improve, reduce the rate of dementia. I think we never went into, apart from our blindness and vision impairments, we are not getting into other areas. But this is a time when should get into other areas of research where we can see how this research impact the sustainable development goals. Because unless your research is helping with these areas, probably I think you can make an impact, but the impact will be not as far as what you can make when you impact SDGs. So look at SDGs as a whole, and how your research is going to impact SDGs, how is going to impact climate, how is going to impact productivity and all that. So there are a lot of papers which came out of productivity and all, but I think dementia is the first ever trial in the world happening with dementia. And then road traffic accidents in stable, which is happening in Vietnam, and KIT, which is on mobile banking, happening in Bangladesh. So we had almost 29, 30 collaborators in that trial. So again, it's like a multi-center, multiple collaboration, because you have to get expertise in different domains. We have the expertise in vision, but we don't have expertise in other areas. So we are venturing into other areas, go to approach people, take expertise, take information, take their expertise, and then probably do a research with their support. So, and this is about engine. And then we decided what should we do in, what should be our focus area of research. And this is what we came up in our department that this is what will be our focus area of research, which is basically looking at health system research and research. Shrivas presented today data on the occupational group. So that is one part of this. So tribal eye health study, it's leading. Health economics with Asha is leading. So there are multiple areas which we are looking at, and also we are trying to build capacity of our people. So we make sure that people get enrolled and get into PhD programs, to get involved in research, get into master's programs, so that we can build the next line for our research. Because we will be gone, but I think the research should go on, and probably this is the framework which we came up, and capacity building and the influencing policies are cut across all the research, and then so that's the overall structure of the research which we. So this will become our focus area of research, and operational research are equally important. So we have people start with operational research questions as one small question, like say outcomes of cataract surgery you were talking in the mark. How do you improve effective cataract surgical coverage or effective cataract surgical coverage, or outcomes of cataract surgery? This is a very, very operational research question. Start small, but put your ideas so that at least once your ideas are there, you start thinking. Once you start thinking, probably you will come with a question which nobody even have thought of it. Sometimes people come and they come with such a question. A junior most faculty in your department can come with a question which you have never thought of, and you start thinking. That's a very right question, and probably you should. So start thinking of question. Keep writing your ideas, because in in a second, so many ideas put in this room. So many people are sitting, and there's so many ideas floating. I want to do this research, that research. Unless you write it down, that things will vanish. So keep writing things. This is my idea. This is my idea, and then go with the idea to a mentor. Probably that's most important, and then probably narrow down to another research question. I think in research, mentor is very important. Unless you have a good mentor, I think you will be totally lost in the desert. Think, yeah, this is six. So this is the number of publications which we this is about our cap. We have almost like more than 400 publications from our research group. Nearly almost 60 projects and multiple grants. And this is the entire team. So it's not like one person effort. I think public health research requires a lot of team efforts, and those who have done it know that you have to get every people on the ground is important. Starting from the health worker who is going to collect, map your village and get people. He's the most critical person because he knows the village very well. So unless you have these people and coming in, people will refuse. I don't have time to come. It's not that they are coming to your clinic. You are going to them. It all depends on how do you convince them, get them, and improve your response rate analysis. So every person is important, and every person has a role to play in research. Not out there.